Assalamu alaikum. Welcome to all today's lecture on non-obstructive atherosclerotic and non-atherosclerotic coronary heart disease. Introduction. Obstructive coronary atherosclerosis and myocardial infarction tend to be predominant topic when discussing coronary heart disease. Many other clinically relevant processes affect the coronary arteries. Today's our discussion will begin with pathology of the coronary artery, intima and media, then move to disease that affect the entire coronary, and conclude with physical abnormalities of the coronary arteries and mechanical disruption of the coronary blood flow. Normal coronary artery and function. The normal arrangement of coronary arteries is for the left main artery and right coronary artery to arise from the ascending aorta 1 to 2 centimeter above the base of their respective coronary sinuses. The left main artery divides into anterior descending and circumflex branches which travel in the interventricular and atrioventricular group respectively. The right coronary artery also travels in the atrioventricular group on the right side of the heart, typically terminating in the posterior descending artery in the inferior interventricular group. This is the diagrammatic picture of the coronary arteries, the left coronary and the right coronary. And the left coronary again divided into circumflex and left anterior descending coronary arteries. Myocardial blood flow is regulated mostly in the coronary microcirculation, where only small changes in arteriolar diameter can result in large changes in conductance and flow as predicted by Poisselius law. For example, a 20% reduction in arteriolar diameter results in a more than 100% increase in resistance and reduce blood flow by more than 50%. That is, arteriolar diameter 20% decrease hole coronary blood flow blood flow resistance 100% বাড়বে এবং blood flow কমবে about 50%. The coronary arteries are lined by we all know that intima, media and adventitia. Intima, endothelial cells and internal elastic lamina. The media, smooth muscle cell and adventitia, external elastic lamina, fibroblast and vasa vasorum. Many macrovascular disease result from mechanical disruption of one or more of these layers, whereas microvascular disease predominantly result from dysfunction of endothelial cell and vascular smooth muscle cell. The endothelium function as a mechanical barrier and also produce a variety of regulatory compounds. This layer also serves as attachment point for surface molecules that attract or repel platelet, leukocyte, and soluble compound in the blood. The elastic lamina acts as a barrier and reinforces the structure of the coronary artery. The contractile tone of the smooth muscle layer regulates resistance to blood flow, thus controlling the volume and distribution of blood flow. This layer also proliferate in response to various disease states. Cells in adventitial layer nourishes the artery, secrete vasoactive substance, and provide the nervous system with feedback on its function. This is the conductance vessel The diagrammatic representation, pre-arteriolar system and arteriolar vessel. This is the angiographic view of microcirculation in the coronary system. Risk factor for developing coronary microvascular diseases. This is diabetes mellitus, hyperlipidemia, hypertension. In addition, some systemic inflammatory diseases such as psoriasis and inflammatory bowel disease are less typically considered to be related to heart disease, but have been linked to coronary microvascular disease. এছাড়াও hyperparathyroidism has been recently described as a cause of coronary microvascular diseases. Endothelial dysfunction. The endothelial plays a pivotal role in coronary autoregulation by release of compound including nitric oxide and other reactive oxygen species and arachidonic acid metabolites. Nitric oxide is produced in response to many stimuli, that is shear stress, systemic tone, sympathetic tone, and muscarinic activity by acetylcholine. Endothelium release nitric oxide and causes dilatation of the arteriole and helps preserve normal parenchymal function by inhibiting inflammation, proliferation, and thrombotic process. Dysfunction of the endothelium is a risk factor for developing atherosclerotic plaque and may exist on continuum of atherosclerotic disease. Oxidized low-density lipoprotein is key to developing both endothelial dysfunction and plaque formation. Presence of oxidized lipid stimulate production of free radicals such as superoxide, which neutralize biologically active nitric oxide. Reduction of biologically active nitric oxide can then alter any of the normal processes it regulates. It increases in platelet activation through the glycoprotein 2B3A pathway by predispose patient to thrombus formation, leading to acute coronary syndrome without obstructive coronary artery disease. Here, this is the diagrammatic presentation of the normal microvascular picture and the microvascular disease picture. In normal condition, the endothelium of the microvasculum produce nitric oxide and prostacyclin, which is the anti-proliferative, anti-inflammatory, and anti-thrombotic, and maintain normal homeostasis. And in diseased condition, the endothelium produce hydrogen peroxide, which pro-inflammatory, pro-proliferative, and prothrombotic, and causes atherosclerotic process. Coronary smooth muscle dysfunction. Coronary smooth muscle cells are regulated by both endothelium dependent and endothelium independent mechanism. Smooth muscle dysfunction may result in spasm, specifically in the microvasculature, sparing the macrovessels, but resulting in the same clinical presentation. Chronically elevated tone in microvessel musculature may be an etiology of slow flow on coronary angiography, which could also explain the observation of angina that at rest, sometimes reported in this patient. Non-obstructive coronary atherosclerosis. In large international registry of patients referred for coronary angiography, the prevalence of the non-obstructive coronary artery disease in women with angina symptom may be as high as 65%. This is less common in men, but not negligible at 14 to 32%. The condition of angina with so-called normal angiography, or more accurately termed non-obstructive coronary artery disease, is increasingly observed and is significantly more frequent among women than men. More detailed analysis with IVAS and coronary CT has demonstrated that most patients with normal angiography actually harbor atherosclerotic plaque that does not encroach on the lumen. Patient with symptoms and signs of ischemic heart disease with obstructive and non-obstructive coronary artery disease. In obstructive coronary artery disease, prevalence more in men than women, predominantly men and older women reduced left ventricular LV systolic function, and diagnosis of ischemic heart disease and guideline specific diagnostic, prevalence and treatment strategies are available. But in non-obstructive coronary artery disease, prevalence more in women, predominantly younger, middle-aged women, preserved left ventricular ejection, left ventricular systolic function, and possible plaque erosion with subsequent thrombus formation, often multiple mechanism for ischemia associated with heightened risk for adverse outcome. Unfortunately, ischemic heart disease is often deferred and delayed. No guideline recommended assessment or management is available except for symptoms relief and CVD risk factor management. Non-obstructive coronary artery disease require better recognition and investigation. Need to develop effective prevention, diagnosis, and treatment approaches, and there is no available guideline for specific diagnosis, prevalence, and treatment strategies like obstructive coronary artery disease. To evaluate for the presence of coronary microvascular disease, a provocative agent and measurement technique must be selected. Within provocative agent, some are dependent on healthy functional endothelium, whereas other act directly on vascular smooth muscle and considered endothelium independent. One is dependent and another is independent process. The most commonly used pharmacological agent for endothelium dependence testing is acetylcholine, which must be administered via intracoronary route. The mechanism of acetylcholine use in normal coronary arteries, acetylcholine release nitric oxide from endothelium, and it overriding its effect at the vascular smooth muscle muscarinic receptor to induce vascular smooth muscle contraction, resulting in vasodilation. In arteries with disease or dysfunctional endothelium, insufficient biologically active nitric oxide is released in response to acetylcholine. These drugs directly affect to activate vascular smooth muscle and causes vasoconstriction. Acetylcholine can be used effectively for distinguishing normal coronary arteries from those epicardial spasm or microvascular spasm. And another agent is adenosine and rigadenosone. And multi-slice detector CT with iodinated contrast can provide an estimate of myocardial blood flow and coronary flow reserve by measuring attenuation changes over time in basal and hyperemic condition and plotting time attenuated curve. This is a CT and coronary blood flow reserve can be measured by CT. Pulse wave Doppler recording of LAD blood flow velocity by transthoracic echocardiography before and during adenosine infusion appear to be a reliable non-invasive method to assess the coronary blood flow non-invasively. And this is the picture of diagrammatic picture of coronary blood flow by invasive procedure. And this is a guiding catheter, and this is the Doppler by transthoracic echocardiography to assess the coronary flow reserve. Treatment of coronary microvascular disease and non-obstructive coronary artery disease. The medical treatment is angiotensin 2 inhibitor or angiotensin receptor blocker and statin have shows promising by reducing symptoms and improving coronary flow reserve in several randomized trial of small sample size. Epicardial coronary spasm. We know the vasospastic angina or coronary spasm. This syndrome includes symptoms typical of angina pectoris but occurring at rest and typically associated with transient elevation of ST segment. Another name is prinzmetal or variant angina or vasospastic angina, because epicardial spasm has a much wider clinical spectrum of symptom and ECG finding and may sometimes overlap with coronary vascular disease, and it is preferred to use simple and clinically broad term, the coronary spasm. Clinical finding, symptoms and ECG changes associated with coronary spasm may occur without ST segment elevation, often associated with ST segment depression and or T-wave changes, and maybe also at time result from small vessel or regional coronary dysfunction. Depending on the severity and duration of spasm and the coexistence of obstructive coronary artery disease, myocardial necrosis, ventricular tachycardia or fibrillation, heart block or sudden death can occur. The specific etiology is not known but is thought to be related to both neurologic and pharmacologic stimuli that activate vascular smooth muscle to contract and severely reducing luminal diameter and hence limiting regional blood flow. Spontaneous occurrence of coronary spasm may occur in a variety of clinical situations, including general anesthesia, allergic reaction, that is histamine induced, hypersensitivity angina, use of argoline derivatives, that is bromocriptine, methyl gonovine, pergolide and lyseride, thyrotoxicosis, hypercholinergic crisis, use of triptan, dobutamine infusion during stress test, use of capecitabine, dolaserine and eliciting substance, that is cocaine, butane, amphetamine, etc. Coronary spasm can occur with mechanical stimulation related manipulation for diagnostic and interventional procedure, that is angiography or catheter or balloon angioplasty. Coronary spasm is more common in younger patients and women than angina pectoris occurring because of obstructive atherosclerosis. However, some degree of atherosclerosis as intimal thickening by IVUS or at autopsy is likely present in all cases of coronary spasm. Cigarette smoking and Asian ethnicity are risk factors for spasm, whereas other traditional cardiovascular risk factors are not strongly associated. A scoring system has been proposed to estimate risk of major adverse cardiac event in patient with vasospasm. Using this system, patient can be stratified into low, moderate, and high risk for major adverse coronary event. This is the risk scoring system for predicting MACE in patient with vasospasm. Uh, Factors are out of hospital arrest, score 4, smoking 2, angina at rest alone 2, organic coronary stenosis 2, multivessel spasm 2, ST elevation during angina 2, beta blocker use for angina 2. And the risk categories are low, intermediate, and high. If scored 0 to 2, the event is 2 to 2.5%. Intermediate risk, that is scored 3 to 5, event 7%, and high risk score more than 5, event is 13%. And this is the angiographic view of coronary spasm during invasive angiography when spasm does not occur on spontaneous during the procedure. This is the coronary spasm. And ECG changes in coronary spasm, that is when spasm occur, is ST elevation. This is the diagrammatic presentation of the ST elevation. And luminal change in coronary spasm. This is the luminal change. Treatment of patient with coronary spasm includes estimation of risk factor, particularly smoking and exposure to noxious fumes such as smoke and gasoline engine exhaust. Calcium antagonist and other are the cornerstone of the treatment, and sometimes with addition of nitrate. Silostazole has recently been suggested to be effective for selected patients with coronary spasm. Those are not controlled by the calcium antagonist. And systemic inflammatory illness. The coronary arteries can be affected by systemic inflammatory illness, both general inflammatory disease and those specific to vascular structure. The vessels are more affected in large arteries, that is aorta, medium sized arteries, that is coronary vessel, and small arteries, that are arterioles. The infectious agent may play a role in a number of vasculitis, that is hepatitis B virus, linked to the polyarteritis nodosa, and hepatitis C virus is a causative agent of cryoglobulin related vasculitis. Bacteria associated with vasculitis include Rickettsia, Coxiella, Mycoplasma, and Toxoplasma. And viral agents include herpes, Epstein-Barr virus, parvovirus, cytomegalovirus, and varicella. The causes of coronary arteritis, which is large vessel vasculitis, Takayasus arteritis, giant cell arteritis, medium vessels, polyarteritis nodosa, and Kawasaki disease. Small vessel vasculitis, microscopic polyangiitis, granulomatosis with polyangiitis, Wegener's disease, eosinophilic polyangiitis, that is Church-Strauss syndrome, antiglomerular basement membrane disease, cryoglobulinemia, globulin A vasculitis, that is Henoch-Conlin purpura, and combined angiitis obliterans, that is Burgess disease. Takayasu disease, that is large vessel vasculitis, The pathological cause of Takayasu arteritis is not precisely known, but it is widely thought to result from autoimmune process mediated by T cell and affect এই যারা মিউট করে নেন, যারা কথা বলতেছেন শব্দ হচ্ছে, that is T cell mediated and affect the vasa vasorum of large vessel with leukocyte infiltration. Typical age of onset is 20 to 30 years of age and affected female predominance, that is 8:1, and peak incidence is third decade of life.
মাহবুব, তোমার এটা মিউট করো।
এই কথা বলতেছে কে?
মাহবুবের ইয়ে থেকে শব্দ হচ্ছে।
সেটা এখনো মিউট করে নাই। Takayasu arteritis affect aorta, carotid, ulnar, brachial, radial, and axillary artery. And symptoms are claudication, fatigue, fever, arthralgia, and weight loss. Clinical examination reveal loss of pulse, bruit, hypertension, and aortic incompetence. And late manifestation include visual loss, renal impairment, and stroke. Granulomatous inflammatory disease of the vessel wall leading to vessel occlusion and weakening of the vessel wall. Although coronary involvement is thought to be uncommon, perfusion defect may be seen in a majority of patients despite a lack of cardiac symptom. No specific serum test is available, but some markers of inflammation, that is C-reactive protein and ESR, are commonly used, and CT and PET are useful for assessing arterial dilatation of the inflammatory activity in the vessel. There are 4 classes of that type 1, 2, 3, and 4. Type 1 localized to the ascending aorta and its branches. The type 2 localized to the descending thoracic aorta and abdominal aorta. Type 3 combine both 1 and 2, and type 4 involve the pulmonary artery. This is the positron emission tomography feature of the Takayasu arteritis, and treatment is high dose steroid and immunosuppressive agent. With appropriate treatment, survival also known as temporal arteritis because of a predilection for the temporal arteries and predominantly of older age, more than 50 years patient. An infiltration of the intima with giant cell can result in glaucoma formation and thickening of the intimal elastic lamina. Blindness and stroke are unfortunate presentation, whereas headache and fever manifestation. And diagnosis is confirmed by the biopsy of the arteries, and imaging studies may shows pathological thickening of the large vessel. Treatment is immunosuppression. And this is the imaging finding of giant cell arteritis. This is transesophageal echo of abdominal aortic thickening in a febrile patient, and this is inflammation noted in fluorodeoxyglucose, that is PET, position emission tomography imaging, and this picture is thickening of the aorta by CT, and this one is inflammation of the on emission tomography, that is hybrid imaging, the combination of the fluorodeoxyglucose and position emission tomography, hybrid process. Medium sized vessel vasculitis, that is polyarteritis nodosa. Polyarteritis nodosa is a chronic systemic disease caused by necrotizing vasculitis, most often affecting the skin and peripheral nerves. The disease is caused by autoimmune response to infectious agent, most commonly hepatitis B virus. And age of incidence is 40 to 50 years of age and male predominance. Coronary artery involvement is present in a minority of the cases, there is 4 to 30%. Coronaries can become thrombosed, resulting infarction and aneurysm and possibly rupture of the coronary arteries. No laboratory tests are specific for polyarteritis nodosa. ANA are typically negative in those cases. Immune modulating drug, including steroid, cyclophosphamide, azathioprine, and methotrexate, are the useful treatment of polyarteritis nodosa. This is the picture of polyarteritis nodosa. And echocardiography of the polyarteritis nodosa shows massive coronary coronary aneurysm, coronary sinus aneurysm in 4-chamber echocardiographic view, and this is the demonstrating the angiographic imaging of coronary sinus aneurysm in polyarteritis nodosa, and three-dimensional echo CT of the coronary dilatation of the coronary sinus aneurysm, and MRI of coronary sinus aneurysm. Kawasaki disease. Kawasaki disease is a common childhood vasculitis that can manifest with coronary abnormality. The disease is also known as mucocutaneous lymph node syndrome and is rare in adults. The typical presentation include erythema of mucous membrane, that is conjunctivitis, leukocytis, and rash, and lymphadenopathy. An infectious agent is suspected, but no causative agent has been identified. Widespread inflammation of medium-sized arteries result in coronary artery aneurysm, typically developing between 4 days and 4 weeks of symptom, and affecting about 25 to 30% of the patient who not treated early. It presents an acute systemic disorder, usually affecting the children under 5 years, and mainly in Japanese and other Asian countries such as China, Korea, and other ethnic groups may also be affected. Pathologically, necrotizing anxieties of the vasa vasorum damage the media and adventitia. Widespread use of intravenous immunoglobulin has resulted in dramatic reduction in morbidity and mortality. Treatment with immune modulating drug is a current era of study. Risk factor for developing coronary artery aneurysm of Kawasaki diseases. What are the risk factors? Delayed diagnosis and treatment, poor response to treatment, age less than 1 or more than 9, male sex, long fever duration, high CRP or ESR, and low albumin, sodium, and hemoglobin. Spontaneous regression of the aneurysm occur in about half of vessel in 1 to 2 years after illness, and predominantly determined by size of the initial aneurysm. Aside from aneurysm development, other cardiac structure and function may affect it. Pericarditis, myocarditis, and arrhythmia have been reported. Non-coronary vascular symptoms including peripheral ischemia and rarely gangrene. Widespread Kawasaki disease undiagnosed in childhood, adult can suffer from late clinical manifestation. In long term, there is 30 years follow-up of Kawasaki patient, only 36% remain free of cardiovascular event. This is the coronary arteries aneurysm in Kawasaki disease in child. Significant aneurysmal dilatation of the right and left coronary arteries and radiographic demonstrating calcification in the aneurysmal segment in cross section. Image of images. It is aneurysmal dilatation of the coronary arteries, right and left system. Now, small vessel vasculitis. Within small vessel vasculitis, two general groups. One is anti-neutrophil cytoplasmic antibody, that is ANCA mediated, and another is immune complex mediated vasculitis. The ANCA associated disease include microscopic polyangiitis, granulomatosis with polyangiitis, previously known as Wegener's granulomatosis, and eosinophilic polyangiitis, previously termed Churg-Strauss syndrome. The disease are most commonly diagnosed in older adult and most commonly affect kidney, lung, eye, nerves, and skin. Presentation includes glomerulonephritis, cough, pleuritic pain, conjunctivitis, optic neuritis, peripheral neuropathy, and purpura. Cardiac involvement may not be considered for part of typical presentation. However, if extensive evaluation is conducted, half of the patient may have some cardiac abnormalities, and MRI demonstrate myocardial scarring. Treatment is immunosuppressive drug. Immune complex mediated small vessel vasculitis, that is Goodpasture syndrome, Hannes-Conlan purpura. Mechanism of immune complex mediated small vessel vasculitis is immune complex deposited in small vessel wall and damage these wall vessels of the body. As with ANCA associated disease, the lung, kidney, skin, nerves, and most commonly affected organ system. Barger's disease, most important for written. Thromboangiitis obliterans is an uncommon, poorly understood, non-necrotizing vasculitis strongly linked to smoking. It typically manifests as a peripheral vascular disease affecting lower extremity. It characteristically affects distal arteries, giving rise to claudication in the feet or rest pain in the finger and toes. Claudication leading to ischemia, ulcer formation, and gangrene is a common sequelae in clinical presentation. Wrist and ankle pulse are absent, but brachial and popliteal pulse are present. It may also affect the vein, giving rise to superficial thrombophlebitis. Infectious, genetic, immunological, and hypercoagulability cause has been proposed. Rarely the coronary may involve. Histopathologic review biopsy specimen can distinguish these from other vasculitis. Tobacco cessation is thought to key management. No specific therapy alter the course of the diseases. Symptomatic therapy with vasodilators such as prostacyclin and calcium antagonist or sympathectomy may also be helpful. Major limb amputation is the most frequent outcome in patient if patient continue to smoke. Transplant vasculopathy, that is transplant related vasculopathy. For some patients with advanced ischemic and non-ischemic heart disease, orthotopic heart transplant is a treatment option. More than 5,000 heart transplants are performed worldwide annually, more than 2,000 in the United States alone. Transplant vasculopathy is a process whereby the coronary arteries become diffusely and circumferentially narrowed with progressive luminal loss. This process differs from typical atherosclerotic process. Finding often include smooth muscle cell proliferation in the intima, fibrosis, and accumulation of T lymphocyte. Uh, Clinically, patient may present with progressive anginal symptom, graft dysfunction, that is systolic dysfunction, and or sudden death. Myocardial infarction can occur with or without symptom because of variable innervation of the transplant heart. Diagnosis of transplant vasculopathy include uh, stress testing, CT, or invasive angiography with or without IVAS. Most transplant centers screen their transplant patient with one or more of these techniques. Transplant vasculopathy is treatment of choice is vasculopathy is transplantation only definitive treatment. Statin, calcium channel blocker, angiotensin converting enzyme inhibitors, and some immunoglobulin drugs may be more effective. PCI is an option for local focal stenosis, but is not feasible for diffuse narrowing. Antiplatelet agent may be given to reduce the risk of myocardial infarction. Congenital abnormalities of the coronary system, including anomalous origin, anomalous course, anomalous branching. Anomalous origin coronary atresia, septate ostia for circumflex or an LAD, coronary arising from wrong aortic scars arising from the pulmonary artery. Anomalous course, that is interarterial, intra-arterial, and retroaortic course, and anomalous branching is single coronary artery. And this is the anomalous origin of the coronary system, that is normal coronary arteries, that is left main coronary artery arising from the left coronary sinus, and in anomalously origin of the left coronary sinus, left main coronary artery from the pulmonary trunk, and or the separately origin from the left pulmonary trunk, left circumflex artery, or LAD from the left from the pulmonary trunk, and here the LCX from the left cusp and the LAD from the pulmonary trunk. This is the diagrammatic picture of the anomalous origin of the coronary artery. That is right coronary artery from the pulmonary trunk, right coronary artery and left main from the left sinus, that is right coronary, and left main from the right coronary sinuses. Myocardial bridging, another anomaly. Coronary arteries typically course over the epicardial surface of the heart. Occasionally, segment of varying length may travel within the myocardium and
reappear on the epicardium more distally in the arterial course. This is sometimes referred to as tunnel artery, but in clinical phenomena is most often referred to the description of the overlying muscle bridging myocardium. On pathological specimen, the coronary artery is surrounded not only by epicardial fat but by myocardium. This can be observed during coronary angiography, where the lumen of the tunnel segment of the vessel decreases, particularly during systole. In autopsy, myocardial bleeding are much more common, more than 15% observed in autopsy than in angiography. Angiography less than 1%, like to degree of bridging and compression of the vessel lumen in variable, possibly related to the varying depth of the tunnel segment within the myocardium. The diagrammatic picture of the tunnel epicardial coronary arteries, that is left main coronary and right coronary system. And this is left main coronary artery enter into the myocardium and reappear into the apical region of the heart. This picture shows the normal epicardial coronaries partially tunneled. Here the bridging myocardium, thin wall myocardial bridge. This is myocardium, thick myocardial bridge, and very thick myocardial bridge. CT angiography of the myocardial bridge, that is picture A, shows multiplanar reconstruction of the LAD. That is, it shows the myocardial, the coronary enters through the myocardium and reappear through the on the epicardium. Another picture is coronary artery fistula. That is another abnormality. An abnormal communication between an epicardial coronary artery and cardiac chamber or major vessel, that is vena cava, subpulmonary vein, pulmonary artery, or other vascular structure, that is mediastinal or coronary sinuses, is known as coronary artery fistula. This anomaly can be congenital or acquired. They can be present at birth or to be observed later in life. Congenital fistula result from failure of fetal structures such as splanchnic vein or intramyocardial trabecular sinusoid to regress. That is diagrammatic picture of the coronary artery fistula. There is that is left main coronary artery communicated with the pulmonary trunk. And causes of the coronary fistula include congenital and acquired. Congenital cause is embryonic and multiple or systemic hemangioma. Acquired cause, closed chest ablation or accessory pathway, percutaneous coronary intervention, right or left ventricular septal myectomy, penetrating or non-penetrating trauma, acute myocardial infarction, dilated cardiomyopathy, cardiac surgery, tumor, permanent pacemaker placement, cardiac transplantation, endometrial biopsy, and coronary artery bypass grafting. Coronary artery aneurysm. An aneurysm of the coronary artery is a pathological dilatation of the entire vessel wall, intima media and adventitia. Normal coronary artery diameter is 4.5 millimeter for the left main and down to 1.9 millimeter in the distal portion of the LAD, and average is 2 to 3 millimeter. Giant cell aneurysm, often defined as those in diameter of more than 4 times the normal, but dilatation of 20 to 20, 30 and 40 millimeter are not uncommon. Percutaneous coronary intervention with stenting or angioplasty, atherectomy and laser based procedure can all result in aneurysm formation. Aneurysm can be diagnosed by CT or echocardiography, and aneurysm causes ischemia or acute coronary syndrome if thrombus formation result in lung narrowing or embolization or occlusion. Causes of coronary artery fistula: atherosclerosis 50%, and congenital, that is 20 to 30%, inflammatory cause 10 to 20. That is Ehlers-Danlos, Marfan, fibromuscular dysplasia, scleroderma, iatrogenic, that is angioplasty, atherectomy and trauma. That is an angiographic picture of coronary artery fistula to ventricle, that is ventricular fistula, coronary artery to ventricular communication. Treatment, medical management of any underlying condition, that is ischemic symptom, and the definitive treatment is surgical ligature or bypass, or cover stent by intervention. Stent is covered with a impervious graft material, that is polytetrafluoroethylene graft. Dissection and trauma. Dissection refers to the separation of the arterial wall and can occur spontaneously or as a secondary event. As a result, two lumen develop within the A vessel, that is true lumen, and another one is false lumen. True lumen, that represents the normal channel of the for blood to flow, and a false lumen, which is a channel that blood flows into and does not have the characteristic wall layers of the normal coronary arteries. That is, true lumen contain all three layers of the arteries, and false lumen, it may within the media or intima or media. Depending on the nature and severity of the dissection, the false lumen can compress or occlude the true lumen, resulting in ischemia, infarction or death. It occurs spontaneously or primary dissection, and most commonly occur in women during pregnancy. This is a picture of the coronary dissection, that is true lumen, false lumen. This is one is false lumen, that this one is true lumen, that is large false lumen. And the dissection may be antegrade or retrograde or spiral dissection. And that is, antegrade dissection are often treated with stenting to prevent further propagation of the dissection and ischemic complication because of the direction of blood flow. And retrograde dissection can be often be treated conservatively without further intervention. Spiral dissection are technically challenging for a percutaneous perspective and often managed either conservatively or with surgical revascularization if ischemic symptom develop. There is a dissection and flow of imaging of the LAD in patient with fibromuscular dysplasia. And this is the diagrammatic picture of the coronary artery dissection in patient with PCI. Diagrammatic shows the morphologic definition of the coronary artery dissection in balloon angioplasty. It is antegrade dissection, and retrograde dissection. Thank you all. এই চ্যাপ্টারটা আসলে পরীক্ষার্থীদের জন্য খুবই ইম্পর্টেন্ট এবং এখান থেকে বিভিন্ন সময়ে শর্ট নোট আসে। তো এটা সবার জন্য, যদিও এটা একটু খুব মানে বেরসিক একটা চ্যাপ্টার আমার কাছে মনে হয়েছে, কিন্তু এটা রিটেনের জন্য খুবই জরুরি। কাজে এটাকে রিটেনের জন্য সবাইকে এটা পড়তে হবে। অভি, কারো প্রশ্ন আছে? হ্যালো
স্যার, আসসালামু আলাইকুম স্যার।
আসসালাম, হ্যাঁ শুনতে পাচ্ছ?
জি স্যার। স্যার, ওই যে নরমাল করোনারি আর্টারি ডায়ামিটার বলছিলেন স্যার, এই 4.5, এটা কি শুধু ওই লেফট করোনারি আর্টারি মেইন ট্রাঙ্কটা?
না না, এইটা হ্যাঁ লেফট করোনারি মেইন ট্রাঙ্ক, এবং এটাকে আমরা তো জানি যে লেফট করোনারি আর্টারিটা এটা বেস টু অ্যাপেক্স হচ্ছে টেপারে, অর্থাৎ বেইজে যতটুকু অ্যাপেক্সের দিকে তত কমতে থাকবে। তো অ্যাপেক্সে বলছে 1.9 মিলিমিটার, এটা একটা এভারেজ, এবং এইটা যখন ডাইলেটেশন হয় তখন বলছে যে 20, 30 or 40 মিলিমিটার পর্যন্ত হইতে পারে। আর রাইট করোনারি আর্টারির এইটা একটা মোটামুটি বেস টু অ্যাপেক্স পর্যন্ত এইটা সমান।
রাইট করোনারি ইকুয়াল। জি স্যার। কত এটা স্যার?
এইটা ওই 4 to 5 মিলিমিটারের উপরে না, এটা এভারেজ হচ্ছে 2 to 3 মিলিমিটার আর 4 মিলিমিটার পর্যন্ত।
তাহলে স্যার এলইডি তো সেম স্যার।
হ্যাঁ, এখানে ডায়ামিটার তো এগুলা ভেরি করবে। তো এভারেজ বলছে 3 to 4 মিলিমিটার এভারেজ ডায়ামিটার।
3 to 4। জি স্যার।
আসসালামু আলাইকুম স্যার। স্যার স্যার, ওই যে হোয়াট ইজ শিয়ার স্ট্রেস স্যার, এই জিনিসটা একটু বুঝি না স্যার। শিয়ার স্ট্রেস যে একটা কথা বললেন স্যার, মানে এটা হোয়াট ইজ শিয়ার স্ট্রেস স্যার, এটা কি স্যার? এই জিনিসটা একটু যদি বুঝাই দিতেন স্যার।
শিয়ার স্ট্রেস, শিয়ার মানে কি? প্রেসার দিয়ে, মানে শিয়ার স্ট্রেস যখন কোনো লুমিনাল স্ট্রাকচারের উপরে কন্টিনিউয়াস প্রেসার পড়বে তখন এটা রাপচার হয়ে যেতে পারে, হয় এটাই শিয়ার স্ট্রেস, এবং এইটাতে এই ডিসেকশন হইতে পারে।
মানে এটা এক ধরনের স্ট্রেস স্যার, এই তো স্যার?
হ্যাঁ, অর্থাৎ শেয়ার স্ট্রেস মানে হচ্ছে এইখানে কনস্ট্যান্ট একটা প্রেসার থাকবে, কনস্ট্যান্ট।
আচ্ছা আচ্ছা, জি স্যার, ওকে।
এই শেয়ার স্ট্রেস।
আসসালামু স্যার। স্যার
ইসলাম বলুন।
স্যার খুব সিম্পল একটা কোশ্চেন স্যার, যেন ভাইবা যদি এইভাবে বলে স্যার যে হোয়াট আর দ্য কমন নন অবস্ট্রাকটিভ কোরোনারি ডিজিজ, কোনটা দিয়ে আরম্ভ করব? হোয়াট আর দ্য কমন নন অবস্ট্রাকটিভ নন অ্যাথেরোস্ক্লেরোটিক কোরোনারি ডিজিজ?
এগুলা তাকায়াসুস ডিজিজ দ্বারাও তোমাকে আমি লিস্ট দেখাই, একটা লিস্ট দেখাইছিলাম না যে তাকায়াসুস ডিজিজ সব ভাস্কুলাইটিস, লার্জ মিডিয়াম, তুমি এইভাবে বলতে পারো, ভাগ করে বলতে পারো, লার্জ মিডিয়াম আর স্মল ভেসেল ভাস্কুলাইটিস। আমি লিস্টটা বাইর করি, করোনারি আর্টারি, এই যে দেখো এইগুলা হচ্ছে, দেখতে পাচ্ছ? দাঁড়াও, হ্যাঁ, এগুলা হইল তোমার নন অবস্ট্রাকটিভ ভাস্কুলাইটিস এর কজ। যেমন তুমি যদি এইভাবে যদি প্রশ্ন করে, তাহলে তুমি এইভাবে ভাগ করে বলতে পারো যে লার্জ ভেসেল, হ্যাঁ, তাকায়াসুস জায়ান্ট সেল আর্টারাইটিস, মিডিয়াম বললে পলিআর্টারাইটিস নোডোসা কাওয়াসাকি ডিজিজ, স্মল বললে আমরা মিডিয়াম জানি করোনারি ভেসেল, তাই তো? মিডিয়াম সাইজ আর্টারি হচ্ছে করোনারি ভেসেল। তো এখানে
স্যার তার মানে স্যার করোনারি আর্টারি একটা আর্টারাইটিস ইনফ্লামেশন হলো একটা কজ,
একটা। আর আদার্স আগে বললাম যে বিভিন্ন মাইক্রো অর্গানিজমের মধ্যে আমরা কি বলছি, হেপাটাইটিস বি হইতে পারে, সি হইতে পারে, তারপরে ভেসেল ভাইরাসের মধ্যে আছে অ্যাবস্টিন বার ভাইরাস, সাইটোমেগালো ভাইরাস, এইসব ভাইরাস, ইভেন করোনা ভাইরাস। ঠিক আছে, এখানে আমি এটা দেখাই নাই, করোনা কোভিড-19 কজেস ভাস্কুলাইটিস। এগুলো নন অবস্ট্রাকটিভ কজ অফ ভাস্কুলাইটিস এবং ইমিউন মিডিয়েটেড। এই যে আমরা বলি না থায়োগ্লোবুলিনিমিয়া, ইমিউনোগ্লোবুলিন এ, যেগুলো হেনোস্কলিন পারপুরা, তারপরে বার্জার ডিজিজ, এগুলা সবই হইলো ভাস্কুলাইটিসের কজ। আর কারো প্রশ্ন? আর কারো প্রশ্ন আছে? স্যার আছেন নাকি আমাদের সাথে? স্যার
হ্যাঁ আছি আমি প্রথম থেকেই শুনতেছি, এক সেকেন্ডের জন্য এপাশ ওপাশ যাইনি।